Video. Video. Founder.
May I start now? Meeting. Yeah. So, yeah. 5, 4, 3, 2, 1. Meeting is start. Yeah.
Only 3% are there. Not to come, I think.
Sir, good evening, sir.
Good evening, sir.
Sir, good evening, sir. Sorry for the late, sir. Sorry.
No, PG or name இல்லாம just thought of calling you and invite the PG to join.
PG வந்திருப்பாங்களே சார். லீனியா லீனியா நிக்ஷல்
ஹலோ சார்.
நீ எதுல ஜாயின் பண்ணிருக்க லீனியா?
சார் நிஷல் அப்படின்னு வரும் சார்.
நிக்ஷல் இதுல ஜாயின் பண்ணிருக்கியா? சரி, ஓகே. வீடியோவும் இதையும் ஆடியோவும் ஆன் பண்ணிக்கமா, அப்பதான் இது பண்ண முடியுமா? சரியா?
ஓகே சார்.
சார், அது இன்னொரு பேர்ல ஒருத்தவங்களோட இதுல ஜாயின் பண்ணிருக்காங்க சார் அவங்க. நிக்ஷல்
இப்ப நேம் காணமேன்னு பார்த்துட்டு இருக்கேன்.
சரிங்க சார். லீனியா அவங்க வந்து நிக்ஷல்ங்கறவங்களோட இதுலயும் ஜாயின் பண்ணி ஐபேட்ல ஜாயின் பண்ணிருக்காங்க போல சார் அவங்க.
ஓகே. Please share your slides, Doctor. Please share your slides, sir.
Linear, share your slide.
2 minutes, sir. 2 minutes.
முத்துக்குமரன் சார் ஜாயின் பண்ணீங்களா சார்? இவர் திருவாரூர்.
முத்துக்குமரன் இல்ல சார், என்கிட்ட பேசினாரே சார், ஜாயின் பண்றேன்னாரு. ஐ திங்க் ஒரு செகண்ட்.
வினோத் கண்ணா is joined. Really good evening, Dr. Vinod Khanna, sir.
Sir, good evening, sir. I've been for a long time searching for the teachers as well as the students.
It's going to be only a few members there இருப்பாங்க சார். Remaining people all will be on the live stream.
வினோத் இது வந்துட்டு எல்லாருமே வந்து யூடியூப் லிங்க்ல வாட்ச் பண்ணிட்டு இருப்பாங்க. இது வந்து only 5-6 தான் இருப்பாங்க. only presenters and coordinators மட்டும் தான் இருப்பாங்க இங்க. சரியா? மத்ததெல்லாம் வெப் லிங்க் தனியா, Zoom லிங்க் தனியா. அது தனி லிங்க், அது தனியா போயிட்டு இருக்கும்.
Yeah, attendees link is different.
When they have time they can see that.
Linear, share your screen, Linear.
Sir, 2 minutes, sir. ஒரு இஷ்யூ வருதுங்க சார். எரர் வருது சார்.
ரெடி செக் பண்ணனுமா அதெல்லாம்?
எஸ் சார்.
The link will be shared to the students and they can see the link after if they have find time now they will see that.
டைமும் லைவும் பாத்துக்கலாம் வினோத். அதுக்கு அப்புறம் ஆல்ரெடி ரெக்கார்டடா இருக்கும், நீ எப்ப வேணாலும் போய் பாத்துக்கலாம், அத போயிட்டு பாத்துக்கலாம்.
Okay, fine. Well, we are also conducting meeting in IAN meetings, Indian Academy of Neurology meetings. We also conduct like this. Only the number of people will be very meager. They will give you the link, they can see at any time. Like that.
அதுதான். இதுல இருந்து ரெண்டு விதம் பண்றாங்க. ஒன்னு வந்து லைவாவும் பாக்குறாங்க, இன்னைக்கு நிறைய பேர் பாப்பாங்க. அதுக்கு அப்புறம் பாக்குறவங்க go for a recorded link from YouTube linkல இருந்து பாப்பாங்க. முத்துக்குமரன், I'll just try to call him. முத்துக்குமரன்.
Sir, you're able to see, sir?
Yeah, it is clear, Doctor.
Yeah. Linear. Okay. You can start, ma'am.
Shall I start, sir?
Just Natarajan sir will introduce after you can start.
Okay.
Otherwise, let me introduce. Good evening and welcome you all for this API-ICP postgraduate training program, virtual program. We have with us this week the faculties from Department of Medicine, the Professor and HOD, Dr. Natarajan sir, as a faculty this evening. Really thank you, sir, for being this faculty for this evening. And we have with us the Professor of Neurology from SMZ Medical College and Hospital, Dr. Vinod Khanna, sir. Really thank you, sir, for being the faculty and specialist neurologist for this evening program of this case discussion on the central nervous system. We are expecting Dr. Muthukumaran, the Assistant Professor from Department of Neurology, Tiruvallur Medical College, to join soon as a faculty from the specialist point of view. Really welcome you, sir, for this evening. And we have with us Dr. Linear Lalita, the final year postgraduate from Department of Medicine, Tiruvallur Medical College, to present the case on central nervous system, probably quadriparesis. And she's going to present the history and the examination findings will be discussed by the faculties, both Dr. Vinod Khanna sir and Muthukumaran sir, as well as Dr. Natarajan sir. Over to the faculties and the postgraduate for the presentation and discussion. Thank you.
Thank you, sir. Thank you for the introduction, and I warmly welcome Dr. Vinod Khanna, who is my colleague, and now he is a Professor of Neurology in Savita Medical College. and Dr. Muthukumaran sir, who is my colleague, sir. And thank you for the opportunity from API, sir, for conducting such meetings, which should be an eye-opener for our postgraduates. It is a boon for them, sir. Let us start the discussion. Linia, just go for a discussion.
Sir.
Yeah, start. Satamadi screen share achema.
Yeah. It's
Enlarge
coming.
பண்ணிக்கோ full வச்சுக்கோ
Yes,
அந்த
sir.
screen.
Yes, sir.
Okay,
Good
start your
evening,
present.
sir. A case of quadriparesis for evaluation. Mrs. Kalai Selvi, 44 years, female, 9th standard. She is a domestic breeding checker for vector-borne diseases worker, right-handed individual from Tiruvarur. Came with chief complaints of neck pain for past 6 months, difficulty in using both upper limbs for past 6 months, difficulty in using both lower limbs for past 3 months, inability to hold urine for past 3 months. Patient was apparently normal before 6 months, after which she developed neck pain, insidious in onset, progressive in nature, sharp pain radiating to bilateral upper limbs, aggravated by neck movements, coughing and sneezing, associated with numbness of both shoulders. Patient also used to get electric shock-like sensation through her back while flexing her neck. Then, after a few days of the onset of the neck pain, the patient noticed difficulty in holding objects in both her hands while doing her normal household work. She also noticed difficulty in mixing food while eating. She had difficulty in writing while she went for her work. She had difficulty in buttoning and unbuttoning her dress. Then, gradually, after a few days, she also noticed difficulty in combing her hair, difficulty in bringing food to the mouth. After 2 to 3 months, patient noticed her slipper slipping while walking, and she was aware of it. She gives history of tripping over toes while walking. Gradually, she noticed difficulty in getting up from squatting posture, difficulty in getting up from chair, difficulty in climbing upstairs and coming downstairs. She also noticed difficulty in rolling in bed and difficulty in raising the head above the pillow. She noticed stiffness of her upper and lower limbs. No history of flainess of limbs or diurnal variation of weakness or muscle pain, and no history of slowness or postural instability. Patient gives history of neck pain, radicular type, radiating to bilateral upper limbs, and history of numbness of both shoulders. Patient is able to perceive her clothes. She is able to appreciate the insect bite sensation, able to perceive hot and cold sensation while bathing. No history of pin and needle sensation, no history of unsteadiness while washing the face, and no history of incoordination in dark. No history of loss of smell, no history of difficulty in seeing objects, no history of defective vision at distant object or color objects, no history of double vision, no history of difficulty in moving eyeballs in all directions, no history of drooping of eyelids, no history of difficulty in chewing food or drooping of the jaw, no history of difficulty in appreciating sensation over the face, no history of deviation of angle of mouth to right or left side. No history of dryness or abnormal watering in the eye, no history of drooling of saliva while drinking, no history of hard of hearing, no history of difficulty in swallowing food, no history of hoarseness of voice, no history of nasal regurgitation, no history of difficulty in turning the head from side to side, no history of difficulty in shrugging the shoulder, no history of difficulty in protruding the tongue, no history of difficulty in clearing food from mouth. Hello, sir. Shall I proceed, sir?
Yes.
Yeah,
Linia,
proceed, Linia.
Patient is able to perceive bladder fullness, but patient gives history of wetting her clothes before reaching the toilet. No history of incomplete bladder emptying after voiding. No history of hesitancy. No history of any interrupted stream of urine. No history of bowel incontinence, altered bowel movements. No history of constipation. No history of abnormal sweating or dryness of skin. No history of postural giddiness.
Linia, 1 minute.
No history. Yes, sir. Yes, sir.
Linia, 1 minute. You said about the neck pain, description
Yes,
of the neck pain. Whether it is aggravated by any coughing or sneezing, the neck pain.
Is there, is there?
Yes, she told, sir.
Yes, sir.
She told.
Then what is it?
It
What
is
is the
aggravated by coughing and sneezing.
Yeah, what is the mechanism behind this? What is the sign called as?
Lermite sign, sir, because the mechanoreceptors are irritated in compression of the nerve fibers, sir. So it causes.
That is some difference between Lermite sign. That is not exactly Lermite. Lermite sign is electric shock-like sensation.
Yes, sir.
You told both the sensations. You told both the sensations. There is a radicular pain and also there is an electric shocks-like sensation while flexing the neck. Both
Yes,
the sensations. You told that actually.
So
Yes, sir.
electric
What is the first
shock-like sensation is Lermite sign. Okay.
Okay,
This
sir.
neck pain which is getting aggravated by coughing and sneezing, what is it exactly due to?
It
What
is
is it
a
sign? Yes.
radicular kind of pain. It is because of the uh, epidural
The
sudden
difference
rise in intrathoracic or abdominal pressure.
in compressive myelopathy also Lermite sign can occur, multiple sclerosis also it can occur, but the radicular pain it specifically occurs in a compressive myelopathy. It is called as degerent sign, in which there is increased intrathecal pressure by coughing and sneezing. So this is mainly to differentiate between whether there is a compression or not. Okay. It is called as
Okay, sir.
degerent sign. Cough induced radicular pain. Cough will induces radicular pain due to increased intrathecal pressure in the compressed cord where the compression takes place. Lermite sign is different. Lermite sign can occur in non-compressive lesions also. It can occur. It is like electric shock-like sensation. We have to differentiate this degerent sign or this cough, neck pain, which is aggravated by coughing and sneezing, can differentiate between compressive and non-compressive lesions also. Okay, proceed. Linia.
And root pain, regarding root pain, how does it spread from the root pain? Can you say which root is involved?
Irritation of the cervical nerve
See,
roots.
can you localize the lesion by the root pain itself?
No, sir.
We can localize it because C5,
Okay,
it
sir.
starts in the neck, radiates to the shoulder and the left upper arm.
Okay, sir.
For C6, it radiates to the thumb and the index finger.
Okay, sir.
For C7, it radiates to the posterior arm and the middle finger.
Okay, sir.
For C8, it radiates to the medial forearm and ring and little fingers.
Okay, sir.
So usually thumb and index finger, if the root pain is radiating, it is C6. Middle finger, it is C7. For ring and little finger, it is C8.
Okay, sir.
Usually C5 pain radiates only to the shoulder and the upper arm. It doesn't extend beyond that.
Okay, sir.
So radiation of pain can also localize to the root involved.
Okay,
Because
sir.
only one root will be compressed, isn't it?
Yes, sir.
Yes, root pain will also localize the lesion.
Okay, sir.
The same like that in the lower limb also. L1, there will be pain in the groin and the upper inguinal region. L2 in the anterior upper thigh and L3 in the thigh and medial knee. And L4 around the medial malleolus and L5 around the dorsum of foot and great toe. So upper limb, the localization is very better. C5 only to the shoulder and upper arm. C6 to thumb and middle finger. C7 to thumb and index finger. C7 to middle finger. And C8 to ring and little fingers.
Okay, sir.
Okay.
This electric shock-like sensation you told about Lermite sign, what is due to? What is the mechanism behind that?
A compression, it is because of posterior column involvement, sir. And there is irritation of the mechanoreceptors, and even in demyelinating illnesses, there is irritation of the mechanoreceptors, which causes electric
Shock-like. So both the type of pain is present in both in this patient, right? It's a radicular pain as well as a posterior column is also involved here.
Yes, sir.
Okay. Okay.
You noticed the difficulty in combing her hair and bringing food to the mouth, Linia.
Yes, sir.
So what is it
Yes, sir.
involved? What is the myotome involved in it? Combing her hair and bringing food to the mouth? Which level is involved? Combing hair. Combing hair, you should raise
Combing hair is deltoid muscle. It needs deltoid muscle, supraspinatus, infraspinatus, sir. C5.
It involves abduction of shoulder. There's for combing hair, C5 is involved. Flexion of the elbow, C5, C6, and external rotation occurs, C5. So it starts from C5, C6. So combing of hair difficulty and bringing food to the mouth both involve C5, C6. Okay.
Okay,
Sir told about teacher in sign, isn't it?
yes, sir.
Do you know any other teacher in eponyms in neurology? Teacher in Drowsy syndrome, teacher in Sotas disease.
Yes.
What is teacher in
Thalamic
Drowsy? Yes, thalamic, post-stroke thalamic pain. Usually contralateral sensory loss following the central thalamic pain. We call it as teacher in Drowsy syndrome. And teacher in Sotas is? It is inherited demyelinating neuropathy, HMSN, hereditary motor sensory neuropathy. And
Okay,
degenerative triad is medial medullary syndrome, what we call it as degenerative triad with contralateral hemiparesis, ipsilateral 12th nerve palsy, and contralateral proprioception vibration loss.
Okay.
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 You told about vector bone. What is her occupation?
She works as a domestic breeding checker, sir, in vector-borne disease like dengue, malaria, like that, sir.
Okay. Okay. Continue.
Why do you ask diurnal variation of weakness for this patient?
In myasthenia gravis, there will be diurnal variation of symptoms, sir.
Any other
Actually,
condition?
you told the weakness is a stiff weakness, isn't it?
Yes, sir. Stiffness.
See, once you say the weakness is stiff weakness, it goes without saying that it is UMR.
Yes,
So,
sir.
நம்ம அதில் ப்ளைல்னஸையோ இல்லை டயனல் வேரியேஷனையோ நம்ம கொண்டு வரணுன்ற அவசியம் இல்லை.
Okay, sir.
ரைட். ஏன்னா ஸ்டிஃப் வீக்னஸ்னு சொன்னதுக்கு அப்புறம் நம்ம எல்லாமே அடி வாங்கிரும் அதுல.
Hold on. I already told stiff weakness, sir.
This diurnal variation weakness கேட்டிருக்கமா. அதே temperature sensitivity weaknessங்கிறது என்ன phenomenon? எதுக்கு கேட்பீங்க? Temperature sensitivity weakness. What is the phenomenon called as? Diurnal variation, okay, at the end of the day they feel weak. அது மாதிரி temperature dependent weakness. Good. Yes. What is the phenomenon called as? In multiple sclerosis, Uthov's phenomenon. So there will be temperature sensitive weakness in multiple sclerosis, similar to diurnal variation in myasthenia gravis and Lambert-Eaton myasthenic syndrome. Okay. Linear?
சிங்கிள் ப்ராப்ளம் தெரியல.
Linear, you're there? Linear?
Yes, sir.
Are you there?
Yes, sir.
என்னன்னா diurnal variation of weakness, you asked to rule out myasthenia gravis or Lambert-Eaton myasthenic syndrome. Similarly, temperature sensitive weakness variation will be there depending on the temperature, which occurs in multiple sclerosis.
Multiple sclerosis, Uthov's phenomenon.
Uthov's phenomenon. Okay, fine. Go ahead. Share your screen.
Yes, sir.
What happened? Is there any problem? Any other problem?
Yes, 2 minutes.
ஸ்லைடு வரல.
ஹிஸ்டரிக்கு போயிடுங்க. ஹிஸ்டரியா ரிலேட்டட் டு
history, completion history.
Continue the history, Linear.
Lina, we are not getting your audio.
Hello, sir.
Yeah.
Yes.
No history of speech or memory disturbance.
I think another phone is switched on with the Zoom.
Sir, audible, sir?
Yeah.
Yes, go ahead.
No history of speech or memory disturbance, no history of LOC, no history of behavior or emotional disturbance, no history of sleep disturbance, no history of delusion and hallucination, no history of seizures, sir. No history of headache, raised ICP, no history of fever, vomiting, neck stiffness, no history of trauma, no history of loss of weight or appetite. Past history, no history of similar complaints in the past, not a known case of diabetes, hypertension, tuberculosis, epilepsy, CVA, and thyroid disorders, no history of surgery in the past, no history of trauma in the past. Menstrual history, regular cycles, family history, no history of similar illness in family members, consumes mixed diet, normal bowel habits, normal sleep pattern, non-alcoholic, non-smoker. Hello, sir.
Yeah.
Continue.
44 years female, admitted with chronic progressive neurological illness in the form of spastic quadriparesis involving bilateral upper limbs followed by bilateral lower limbs, which was asymmetrical in onset, which was preceded by radicular type of neck pain radiating to both shoulders, associated with numbness and bladder disturbance in the form of urge incontinence, with no history suggestive of higher mental functions, cranial nerves, and cerebellum involvement.
Where exactly the numbness, ma? Only in the shoulders,
Yes, sir.
not below that.
No, sir.
So, as per the history, the numbness is only pertaining to the shoulders, bilateral shoulders.
Yes, sir.
Okay.
Bilateral shoulders, she's telling numbness, sir.
Okay.
So where you want to localize a lesion now? Probable diagnosis after this, summarizing the history.
Yes, sir. The likely structure involved is spinal cord, cervical spinal cord. I would like to localize above C5, sir.
You have to localize each and everything. The patient has got quadriparesis, isn't it?
Yes, sir. Yes, sir.
Quadriparesis, where do you localize?
Above C5, sir.
Quadriparesis, spastic quadriparesis, isn't it? We localize it to bilateral corticospinal tract above C5.
You told that there is a neck muscle weakness also.
Yes,
As
sir.
per the history, she has difficulty in lifting the neck from the pillow.
Yes, sir. She has difficulty in lifting the neck muscle weakness is also there, sir. So
So what are the
C2
muscles which are involved for neck flexion?
sternocleidomastoid for extension and trapezius, sir.
Sternocleidomastoid for what and trapezius for what?
Trapezius is for flexion, sir.
Abhiya, are you sure?
Sternocleidomastoid for sternocleidomastoid for flexion, sir.
So bilateral sternocleidomastoid is for flexion.
Yes, sir.
So now where do you localize? So
C2,
trapezius is for what?
C2, C3 can be localized.
So 11, which supplies the sternocleidomastoid?
sir.
Stenocolum
Preficious
Stenocolum acid is supplied by. Hello? Are you there?
Hello.
சொல்லுமா. Tell me.
Hello, sir.
Sternocleidomastoid is supplied by.
What is the nerve supplying sternocleidomastoid muscle?
Sir, I'm not audible, sir.
Sir is
You hear-
asking, what is the nerve supply of sternocleidomastoid? What are the root supply?
Linear.
C2, C3, sir.
Yes, C2, C3. What is the nerve involved?
Hello, sir. C2, C3, sir.
What is the nerve involved? Yes, C2, C3, sir.
Correct.
What is the nerve involved?
What is the nerve involved?
Spinal axillary nerve, sir.
Okay. So how do you localize C5?
C5
Now-
biceps, sir.
Then now you localize. Based upon the finding, now you localize. Now where we put the lesion now?
Actually, above C2, sir. C2, C3.
So it is in the, what is upper cervical cord?
What do you mean by upper cervical cord and lower cervical cord? Where the transition is there? Linear, your network is good or not?
Yes, sir. Good, sir. I'm audible, sir.
Yes, you are audible. You are not replying to any of the. Whether you know or not, you should say.
Yes, sir. C1, C2, C3, C4 is upper cervical, sir.
So now where do you localize the lesion based upon the finding?
Upper cervical, sir. C1, C2, C3, C4.
So, okay, done. That's it.
Upper cervical cord means we have to also ask for diaphragmatic weakness. Any history of orthopnea also you should ask for.
Obviously, you should ask that.
Yes.
In your history, it was given as slippers slipping while walking, and she was aware of it. That is what your history, la?
Yes, sir. She was aware of that, sir.
Slippers slipping from her legs. Okay. So what do you mean by that?
In sensory ataxia, the patient will have unawareness, sir. But here, the patient is aware that of that, sir.
Why? This actually what you're saying is indicating a loss of proprioceptive impulse. So that is a dorsal column involvement. But being aware means that the patient has a visual feedback which is compensating for the loss of position sense. Okay. So this is classical of posterior column dysfunction. That is what you want to say. See,
Yes,
aware
sir.
means the patient has a visual feedback. If you ask her to close the eyes, only she will not be aware. By only watching through her impulse, she is getting that is slipping away. But she doesn't have any feeling. That is a loss of joint position senses there for her. So that is what you have said in your history. Slipper slipping while walking, and she was aware of it. That means she is having a severe posterior column dysfunction.
Yes, sir.
Based on your history.
Yes, sir.
Okay.
Is there any other type of pain you come across in spinal cord lesions? You was told about radicular pain that is due
Yes,
to
a funicular type of pain, which is a deep aching pain, can be seen in intramedullary lesions, sir.
Like?
And intramedullary lesions like chordoma.
Syringomyelia.
Syrinx. For pertaining to our case, syrinx.
And even local neck pain, vertebral pain can occur. Funicular pain is cord pain, sir.
Okay. Okay. This patient, what type of pain this patient have?
Radicular pain, sir.
Okay. So based upon the findings, as per the history, what could be the probable etiology for this patient?
We have to localize. Weakness has been localized to.
Okay. We'll localize the weakness. Fine.
Yes.
We'll localize the weakness. Symptomatology will analyze. Okay. Done.
Yes.
Okay, then proceed to the general examination. Go for general examination. Share your screen.
History.
History.
The summary போடு அப்படியே அதுல. We localize quadriparesis with neck muscle weakness to bilateral corticospinal tract above C to C3, isn't it?
Right.
Yes. Second, she has bladder symptoms, isn't it?
Bladder. Tell about the
bladder. Whether it is a storage symptom or a voiding symptom.
It's a voiding symptom, sir.
It's a storage symptom because urge incontinence is due to sudden urges, Leah.
Yes, sir.
It's a storage problem. Voiding you will present as hesitancy, retention, and straining like that. Voiding problem will be there. So this is a storage problem actually. Patient is having urgency and urge incontinence.
Okay, sir.
So
where do you localize the bladder now?
Infrapontine suprasacral region, sir.
What is the commonest presentation?
Human bladder, sir.
Okay. What is the common symptoms in these human bladders?
Human bladder, it will be a small contracted bladder, sir. And the patient will have urge incontinence, and patient will have urinary frequency and urgency, sir.
So based on this urge incontinence, which is detrus or hyperreflexia, where you want to localize the lesion based on only urge incontinence, from above which the lesion is localized?
Suprasacral, sir.
To S4. Above S4 it is there due to the parasympathetic center above S4.
Yes.
We call it as human bladder. We call it as detrus or sphincter dyssynergia. Okay.
What
why do you
bedside test will confirm retention of bladder? What bedside test can you confirm it is a retention of bladder? This is urge incontinence, but the retention of bladder, how will you confirm bedside test? Are any investigation to confirm retention of bladder?
No.
Yeah, you have to go for residual post-void residual urine by ultrasonogram. If it is greater than 100 ml, it is retention. Okay. Retention will always suggest a lower motor neuron lesion or a conus lesion. It is possible. But here what you said is urge incontinence. Okay.
Put the summary slide actually.
Okay, sir.
Yes, quadriparesis we localized. Radicular type of neck pain radiating to both shoulders. Where do we localize that?
Radicular type of neck pain.
See, only it is radiating to the shoulders. We can localize only to C5.
C4. Okay, sir.
With the numbness.
So it radical localized to C5, C4, C5.
C4, C5. Yes. Bladder disturbances, we UM and bladder. No other involvement. So combining all these things, what do you say?
It is a spastic diagnosis, sir. It looks like compressive myelopathy, sir.
Why do you want to say as compressive myelopathy? What is myelopathy and myelitis? Difference between myelopathy and myelitis?
Inflammation.
Myelopathy, any pathological process that leads to spinal cord dysfunction, we call it as myelopathy.
Okay, sir.
It may be either inflammatory or non-inflammatory.
Okay, sir.
Inflammatory, you call it as myelitis.
Yes, sir.
Yes. This is myelopathy, not myelitis.
Yes, sir.
Yes. We can use myelitis and inflammatory myelopathy interchangeably.
Okay, sir.
Okay.
What are the inflammatory myelopathies? Inflammatory myelitis? You know?
Longitudinally extensive transverse myelitis, sir.
Then? Example?
Post-viral myelitis, sir.
Longitudinal extent transverse myelitis can occur in many conditions. What is the main condition that causes
Commonly we come
LETM?
across LETM.
LETM.
Recently, we discussed in our fission conference.
It can occur in NMO spectrum disorders and MOG associated diseases, sir.
Fine. So myelitis can be short segment myelitis as well as long segment myelitis. Common etiology for the short segment is multiple sclerosis, and long segment is neuromyelitis optica as well as MOGAD. Okay. So you have localized that it is in the posterior column. How do you localize that posterior column? Based upon your summary.
Posterior column, actually only
So numbness is there, radicular pain is there. Because of the radical numbness is also maybe distributed to the shoulders.
yes, sir.
We can stick on to the radical itself.
Okay,
You have put posterior column.
in history,
Lermite sign is there, isn't it?
You should tell that. You should tell that.
okay,
In
sir.
the history, you are told that there is an electric shock-like sensation while flexing that. You should tell that. Okay. Fine. So based upon that, I localized to posterior column. Okay, done.
So the symptoms are there for a period of
It is present for 6 months now, sir.
6 months. So this is a chronic myelopathy, isn't it?
Yes, sir.
How will you classify the temporal profiles of myelopathy?
Depending on the duration, sir.
Yes.
Less than 6 hours, it is hyperacute, sir.
Yes, very good.
6 hours to 2 days, it is acute, sir.
Yes.
2 to 21 days, it is subacute. And greater than 21 days, it is chronic, sir.
Chronic. Okay. So this you call this patient we consider as non-inflammatory myelopathy, isn't it?
Yes, sir.
Yes. Inflammatory myelopathy that present chronically. What are the conditions that can present chronically? Inflammatory myelopathies. Because infection and NMO spectrum disorders are acute to subacute only.
Yes, sir.
Placid myelitis, post-infectious myelitis are all hyperacute, acute, and subacute only.
Okay, sir.
What are the inflammatory myelopathies that can occur chronic?
Multiple sclerosis.
Multiple sclerosis is also acute only. Acute to subacute only, relapsing and remitting.
HIV, HTLV associated myelopathies, sir.
Those subacute, chronic is very rare. Generally, autoimmune and other rheumatology disorders, paraneoplastic myelopathies will be of chronic.
Sjogren's syndrome, SLE. Okay.
Sarcoidosis, Sjogren's, and SLE-related myelitis can occur as a chronic myelitis. What about myelopathies? Hyperacute myelopathy, non-inflammatory myelopathies.
It is hyperacute is mainly because of vascular causes,
Yes,
sir.
vascular. Anterior-spinal artery, posterior-spinal artery occlusion. Yes.
Occlusion. It can unpaired anterior spinal artery. It can cause cerebral paraplegia, sir.
Yes. Okay, this is a case where we suspect chronic non-inflammatory myelopathy. Most commonly,
cervical compressive myelopathy.
compressive myelopathy.
So leave that compression. Patient having a bilateral corticospinal tract involvement as well as posterior column involvement. Is there any other etiology you can say this patient without compression?
Any other treatable conditions?
Any other any other treatable conditions?
That can present with bilateral corticospinal tract and posterior column involvement.
B12 deficiency can present.
Yes, metabolic and toxic myelopathies. Yes.
B12 deficiency and
Yes.
even copper deficiencies, sir.
Yes.
What is hereditary spastic paraplegia?
Sir?
What is the hereditary spastic paraplegia? HSP.
Mostly family history will be present, sir, in hereditary spastic paraplegia. It can occur as autosomal dominant or recessive.
Okay. So what commonly structures? What structures involved in HSP?
Ataxia can be there, sir. Ataxia and
So most commonly corticospinal tract as well as posterior column.
Corticospinal and the posterior column will be involved.
Based upon our finding, I asked this. Okay, right.
What are the other conditions where dorsal columns and costocortical tracts are involved other than B12 deficiency, copper deficiency? What else?
HIV, HTLV can.
Yes. Nitrous oxide.
Nitrous oxide. Okay, sir.
Yes, nitrous oxide. What else?
Conso.
Yes, conso. Conso is due to?
Cassava consumption, sir. Because of bitter cassava consumption, sir. Unprocessed.
Lathyrism?
It is because of kesari dal consumption, sir.
What are other drugs that can cause myelitis?
Antidiarrheal drug called siloquinol can cause SMON, sir. Subacute myeloopticoneuropathy, sir.
Yes.
Methotrexate can cause, sir.
Yes, other immune checkpoint inhibitors also.
Like etanercept, infliximab, adalimumab, sir.
Yes.
And Linia,
Yes, sir.
you have asked about HIV history. In HIV, what is the characteristic myelopathy which occurs? HIV myelopathy.
Vacuolar myelopathy, sir.
Yes, clinically, how can you identify what is the typical presentation of HIV vacuolar myelopathy? Why this case cannot be related to it? Because usually it occurs as progressive spastic paraparesis. Okay, legs will be involved more than arms, but here it is opposite. Arms is involved, and there will be definitely dorsal column loss. Yes, here also dorsal column loss is there. Bladder involvement will be very, very late in such conditions. But here, early bladder involvement, you have got urge incontinence, you have got. So HIV myelopathy can be ruled out by this actually.
Fine.
So shall we proceed to examination, general examination? Linia, proceed to general examination.
So what could be the etiology based upon the findings? History.
Patient is
History based upon it. What is the etiology? What could be the etiology?
Compressive cervical myelopathy, sir. Etiology.
Where is the compression? You are localized above C4, above C5. Above C1 to C4, you are localized.
Yes, sir.
What is the commonest site for compression?
Cervical region.
Which segments
cervical
are
and
common?
lumbar regions are common.
I'm asking in the cervical region, what is the commonest site for compression in the case of
C4 to C7, sir.
Generally, compressive myelopathy, the lower cervical spine will be affected.
Okay, sir.
Okay. Here we are localizing it because of that neck muscle weakness. We are localizing it to upper cervical spine.
Okay, sir. So, CV junction anomaly.
In that?
Basilar invagination.
Why? Why? What is basilar invagination?
It is a type of the odontoid process migrates into the foramen, sir. Foramen magnum, sir.
That is different. That is odontoidium. Okay. Okay. So either should be in a CV junction or not, means there either should be the lesion in the occipital bone.
Yes.
Or in the foramen magnum or in the atlas or axis. That's all. These are the four structures involved.
Okay.
Is there any pain? You have told a radicular pain. Is there any pain can attribute to this? The pain is connected to this anyway?
The patient said that the patient is having neck pain
Neck
and
pain,
shoulder pain. Yes.
neck pain
Neck
and
pain and shoulder pain only.
So as per your history, it is an extradural pathology, le?
Yes, sir.
Okay, fine. Proceed.
Yeah, one more thing in structural myelopathies, the common symptoms will be the dexterity changes. That is classical of myelopathy, degenerative myelopathy. Difficulty in buttoning, difficulty in manipulating small objects, difficulty in writing, like that.
Okay.
Yes. Continue.
A patient is conscious, oriented, afebrile, moderately built and nourished, no pallor, icterus, cyanosis, no clubbing, lymphadenopathy, pedal edema, no neurocutaneous markers, no markers of tuberculosis, HIV, syphilis, no kyphosis, scoliosis, spinal deformity, finger or toe deformity, no cheilitis, glossitis, hyperpigmentation of knuckles.
Yeah.
Hello, sir.
Continue.
No peripheral nerve thickening, no Charcot joint, no trophic ulcer, no ptosis, meiosis and anhydrosis, no paradoxical breathing. Pulse 78 beats per minute, regular in rhythm, normal volume, no vessel wall thickening, felt in all peripheral pulses, no radioradial or radiofemoral delay, blood pressure 110/70 mmHg measured in right upper arm in supine position, 120/70 mmHg measured in right upper arm in standing position, SpO2 97%, respiratory rate 14 per minute, temperature 98, no carotid bruit. Anthropometry, height 150 centimeter, weight 44 kg, height neck ratio is 15, sir, and BMI is 19.6. Conscious, patient is conscious, oriented to time, place, and person, memory intact, right-handedness, language is normal, reading is normal, writing is impaired, sir, because she is not able to write properly. Mood and emotions are normal, sleep cycle is normal, sir. And coming to the cranial nerve examination, olfactory nerve is normal, optic nerve is normal, oculomotor, trochlear and abducens nerve normal, trigeminal nerve, sensation over face, she is able to clench the teeth, corneal and conjunctival reflex is present, and jaw jerk is normal, sir. And facial nerve is normal, sir. Vestibulocochlear nerve, glossopharyngeal and vagus nerve, spinal axillary nerve and hypoglossal nerve, normal, sir. Shall I continue, sir?
Continue.
Motor system inflammation.
Linear. What are the card lesions which can be associated with cranial nerve involvement also?
In olfactory nerve, anosmia can happen in any spinal cord injury, like injuries which RTA, which is associated with olfactory bulb injuries, sir. Anosmia can occur, sir. And in Refsum's disease, anosmia and spinal cord involvement can occur, sir. Regarding optic nerve, optic neuritis can occur in multiple sclerosis, sir. So optic neuritis is involved, sir.
Optic nerve can be involved in any demyelinating neuropathy.
Demyelinating.
MS, NMOS of disorder or MOG antibody disease, anything can occur.
And in spinal cord, in Horner syndrome, patient can have ptosis, sir. Ptosis, meiosis, and hydrosis, sir. Next, facial nerve involvement can be seen in Guillain-Barré syndrome, sir. Next.
What we are asking is spinal cord involvement with cranial nerves.
Yes, sir.
No need to say about GPS. Okay.
Okay, sir. And even in high cord lesion, dysphagia, dysarthria can occur, sir.
Okay, proceed.
Okay, Patient in supine position, bilateral upper limb on the side of the body, bilateral hip in neutral position, bilateral knee joint in neutral position, bilateral foot plantar flexed, sir. Bulk is normal, sir. No atrophy of the muscles. Tone is hypertonia is present, sir. And power, neck muscles flexion 3/5, extension 4/5, shoulder abduction 4/5, adduction 4/5, abduction 3/5, flexion 4/5, extension 3/5, flexion 4/5, and extension 3/5 for elbow, wrist flexion 4/5, and extension 3/5, sir. And thumb flexion, abduction, adduction, apposition, and extension 3/5, finger flexion and extension 3/5, hand grip 50%, sir. Power in the lower limbs, flexion 3/5, extension of the hip 4/5, knee flexion 3/5, extension 4/5, ankle dorsiflexion 3/5, plantar flexion 4/5, sir. And toes flexion 4/5.
Linear.
Yes, sir. Yes, sir.
In higher mental functions, what you have written is writing is impaired.
Yes, sir.
That is what you have written.
Yes,
So
sir.
what is the higher mental function involved in writing impaired in this patient? You said there is no cognitive decline in this patient. Patient seen as normal. Higher
Yes, sir,
mental
but
function is normal. Then why did you mention writing is impaired in this patient?
Writing may be difficult due to motor weakness, isn't it?
Motor
Then
involvement.
you have to put it in motor system examination, not in higher mental functions.
okay, sir. Okay, sir.
That is due to motor weakness, spasticity, or any finger control loss. It is due to C7T1.
Yes.
So you should have put it under motor system examination, not under higher mental functions, in which you should have said writing impaired should not be said in that, because what you have said means there is some amount of the higher mental function impairment is there. That is a feeling we have got from it. Okay, you have to put it in motor system
Motor.
examination.
Okay.
Is there any writing center in the brain?
Writing. Writing center in the brain.
The posterior part of middle frontal gyrus, there is a center called Exner center.
Okay, sir.
So most
Broca's area, almost Broca's.
Broca's area. Just. Okay, sir.
Exner's area. Lesion called
Yes, yes.
Exner's area that is responsible for writing.
Yes, it is above the Broca's area.
Yeah. This is in the middle frontal gyrus. Posterior part of the middle frontal gyrus. We call it as Exner's center, which is responsible for writing in the brain. Okay. Right. Proceed.
Superficial reflexes, corneal reflex present, conjunctival reflex is present, abdominal reflex is present, plantar bilateral extensor, sir, jaw jerk is normal, sir. And deep tendon reflexes, trapezius 3+, pectoral 3+, biceps 3+, triceps 3+, supinator 3+, finger flexion 3+, knee jerk 3+, patellar clonus is present, ankle clonus is present.
When clonus is present, it is 4+, isn't it?
Yes, sir.
Then why do we put it as 3+ in knee jerk?
Knee jerk, okay, sir. 4+. Regarding sensory system examination, pain and temperature was normal, sir. And
In bulk examination, whether there was wasting anywhere?
no wasting, sir.
No wasting. Okay,
No
no wasting
wasting.
anywhere.
Yes, sir.
Even in the hand muscle, there was no wasting.
No wasting, sir.
Okay, continue.
Regarding sensory system examination, spinothalamic tract pain and temperature was normal, sir. And posterior column, fine touch, vibration, and joint position was normal, sir. Cortical sensation, normal tactile localization, 2-point discrimination, graphesthesia and stereognosis, sir. Cerebellum, finger nose test is normal. Finger nose test normal. Heel knee test is normal, sir. Romberg's negative, no nystagmus, no intentional tremor, no titubation. Patient is having a spastic gait, no postural hypotension, no resting tachycardia, no abnormal sweating, no flushing, no signs of meningeal irritation. Hello.
Yes.
Yes.
Continue.
Paraspinal and spinal tenderness is present. Actually, it is sorry, so spinal tenderness only is present over C2, C3, C4 vertebrae. Sir. Short neck is posterior hairline. No kyphosis, scoliosis, or gibbous. No bed sores or trophic ulcers. No tuft of hair. This is the patient picture, sir.
Continue.
Other system examination, CVS S1, S2 plus, no murmur, RS bilateral air entry plus no added sound, parabdomen soft, no organomegaly. That's all, sir. Provisional diagnosis, a case of chronic.
The reflexes videos videos போடலாமே
Yes, sir, I will share the videos, sir.
Only motor involvement, right?
Yes. As per the findings, only motor involvement. Can spinal cord problem occur without sensory involvement, Linnea?
Motor neuron disease, sir.
Yes, very good. Motor neuron disease. Either motor neuron disease also.
In that motor neuron disease, which only has human signs.
Amyotropic.
That is with both UM and LM. Sorry, it is asking only UM and lesions.
Only
No
human
LM.
motor neuron disease. Only corticospinal tract.
It's primary lateral sclerosis.
Primary lateral.
PLS.
Yes. And any other spinal cord disease where there is only motor function and no sensory symptoms.
Polio, sir.
No. That is anti-tonsil disease. Spinal cord disease. Only say hereditary spastic paralysis. Main thing is anterior spinal cord syndrome.
Anterior spinal cord syndrome. Okay.
Yes.
So in these cases, you have to know which are the spinal cord diseases. One is only human signs. That is only motor involvement.
Yes.
You already told the DD. Right? HSP, PLS, HTLV, tropical spastic paraplegia. Everything.
Yes.
Okay. Right. Then what is the video?
This is the video, sir. Shall I share, sir?
Yes. Describe the gait.
Spastic gait, sir.
Spastic gait. Wide based, narrow based.
Narrow based, sir.
Okay. Was there any tripping of toes in the history? No.
It was present, sir.
Okay.
நீங்க ராம்பர்க் சைன் டெஸ்ட் பண்ணி பாத்தியா?
Yes, sir.
எப்படி இருந்தது?
Romberg sign was negative, sir. No swaying, sir. Actually, one mild swaying, but not
your
very.
Your history said slipping. She is able to find out the slipping of slippers from her foot. Okay, with
Yes,
her
sir.
eyes open. have you asked history whether eyes closed or not? Because if that would have been the correct history, means rhomboxane would have been positive. Sensory ataxia would have been there. Have you tested properly?
Yes, sir. I have done rhombox tests.
But history doesn't correlate correctly with your rhomboxane. History only said slipping of slippers. She could note it only with her eyes open, aware of it.
Yes.
Okay, have you tested slipping of slippers, whether she can feel it without her eyes opening? You should test it actually history. Then only you can come to a conclusion. That means rhomboxane, if what is the history you have said, that means the rhomboxane should have been positive. Have you demonstrated in the video here?
Rhomboxane not demonstrated, sir. Only ankle clonus and patellar clonus, the exaggerated reflexes, sir.
Okay, okay. Yes.
The history, there was involvement of posterior column. History
Yes,
was
sir.
favored. Yeah. Rhombox can be due to involvement of large fiber or posterior column.
Okay, sir.
What is the difference between large fiber neuropathy and posterior column involvement, ma? Do you know that?
Large fiber neuropathy,
What is the
peripheral.
sensory? I'm asking about sensory. I'm asking about sensory. How do you differentiate a large fiber neuropathy from a posterior column involvement?
Because both the conditions, there will be positive rhombox.
Glove and stocking, sir, in
Correct.
large fiber neuropathy, sir.
Correct. Then
Then
in posterior column.
in posterior column, below on sensory level, it will be below the lesion, sir.
Then
Normally, the reflexes also will be brisk in posterior column involvement and spinal lesions, sir.
okay.
In peripheral neuropathy,
Hello. Okay.
sensory level will be absent, sir, in large fiber neuropathy.
Okay.
Whereas in posterior
Don't-
column lesion, it will be there, sir. Posterior column.
Posterior column, there will be other card symptoms and signs will be there.
Is a hyperreflexia will be there, sir. Spasticity, hyperreflexia will be there, sir. Hello, sir.
Yes, continue.
You said there is a spinal tenderness present over C2, C3, C4, Denia?
Yes, actually, the patient's spinal tenderness is telling all over the regions, cervical region, sir.
But where did you localize the vertebral level?
Above C5, sir.
Well, exactly vertebral level, based on your spinal tenderness only, you can say where was the maximum point of spinal tenderness, if at all the patient would have said correctly. You have put it as C2, C3, C4, something, I forgot it.
C3, C4, C5, sir.
Okay. If this is a non-traumatic case, if you have spinal tenderness exactly at C3, C4, C5, what is the expected differential diagnosis? In a traumatic, you can get it. Okay.
Okay, sir.
But apart from traumatic, non-traumatic, what are the conditions you will have a spinal tenderness at any level? You should localize. If it is in C3, C4, C5, what is the localization you have?
Degenerative disc disease, sir.
Degenerative disc disease. Okay, in CV junction anomaly, what will be there? Can you get spinal tenderness?
Yes, sir. We can have, sir.
Yes. If the spinous process is abnormal, you can have it.
Yes,
What
sir.
are the CV junction anomaly you know?
Basilar invagination.
Okay.
Atlantoaxial.
Yes. In which the spinous process, if it is palpably abnormal, you can get it. tenderness also. Okay. Apart from that, TB spine abscess, epidural abscess, you can get it. Infectious or inflammatory conditions. And very rarely, bony metastasis can also present with spinal tenderness. These are all non-traumatic causes. Traumatic, okay, you can have in orthopedics. These are all non-traumatic causes. But here, if you say C3, C4, C5, that is spinal tenderness, you localize the spinous vertebral level, then you can think of CV junction anomaly also here. Okay.
Okay, sir.
Okay.
A case of chronic asymmetrical spastic quadriparesis with involvement of sensory system with bladder involvement.
Sensory எங்க இருக்கு? Sensory தான் இல்லையே.
Yes, sir.
ம்.
With bladder involvement without involvement of higher mental function, cranial nerves, cerebellum, bowel and autonomic nervous system. Possible site of lesion is spinal cord. The disease.
You said there is earth incontinence, la?
Yes, sir.
Then?
Yes, put it as bladder involvement only. With bladder involvement only.
With bladder involvement. You should put it as with bladder involvement.
Yes, sir. The possible site of lesion is spinal cord. The disease being compressive myeloradiculopathy. Sir.
Okay, what is the differential diagnosis?
Trapezius, sorry, that trapezius, what are the reflexes which are this? Reflex level? What is the reflex level?
Actually, scapulohumeral reflex is brisk, sir. Pectoral reflex is brisk.
Trapezius was also brisk. You were doing
trapezius, you told that it was brisk. Now localize the reflex level. So trapezius level, trapezius jerk is brisk means what?
Trapezius.
Again, same thing. What we asked for sternocleidomastoid, Master Doctor?
Is sir. C2, C4, sir. C3, C4, sir. Reflex level C2, C3.
C2, C3. Okay. Right. Just
motor level also, it will be above, it will be C2, C3 because the patient had neck flexion weaknesses also, isn't it?
Yes, sir. Yes, sir.
Yes. It is supplied by the 11th now. Where do you localize? Where is the spinal accession of nucleus?
Where is the 11th nucleus?
So it is brain medulla, sir.
Take a lot of time for this.
Medulla, it is also there in the card also. Okay. Okay. So based upon the reflex level, you localize above C4, huh?
Yes, sir. Above C4, sir.
Okay. Spinal tenderness was there clinically?
Yes, sir. Yes,
clinically,
sir.
you put it as C2, C3, but here you put it at vertebral level as C3, C4, C5. Why? The almost vertebral level, reflex level, and motor level are all localizing to C2, C3 only.
Still more upper than that. C2, C3 level. Okay.
See, your findings and this localization should correlate, isn't it?
Yes, sir. Sorry, sir. I'll change.
I can put it still more precise. Instead of putting it above C5, you can put it like that.
Okay, sir.
Fine.
Based on this, what are your differential diagnoses based on this level?
Based on this probable diagnosis, I first is actually CV junction anomaly is a possibility because of the short neck and height neck ratio increase, sir. And other differential diagnosis.
What you have written is increased height neck ratio. That means long neck. That is what you have written. But you have written the next point is short neck is present for her. How do you correlate this?
The normal height neck ratio, tell that. What is the normal height neck ratio?
So normal, if it is greater than 13, sir, we can take it as
Normal height neck ratio. What is the percentage of normal height to neck ratio? What is the neck length proportion of total height?
6 to 8% of body height, sir.
10 to 12, 10 to 12 percentage.
10 to 12 centimeter.
Percentage of the total height. Neck length should be 10 to 12% of the total height. And if the ratio, there is that percentage is 15% or more, then it means it is approximately a long neck. Okay. A short neck is below 10, that is 8%, at 8 to 10%, you set it as a short neck. Here, what is the height neck ratio?
15, sir.
15 is high normal. Then you're saying it is a short neck. Have you measured it correctly? Because usually short neck will be associated with CV junction anomalies. Okay.
Yes, sir.
But here you have put the percentages 15%, which is slightly higher than the high normal side. So it means a long neck. You cannot, you are contradicting your findings, no?
Yeah, if it is more than 13, it is called a short neck.
Yes, sir. Yes, sir.
He's putting it as a ratio, sir. Not as a percentage.
It is a ratio. The slide put தெரியும்.
Clinically also it looks like short neck only.
Short neck da. Where you have put night neck ratio 15 ratio. You have to tell that it is a ratio. Okay.
Okay, sir.
Is that short neck da.
Idume illa Vinod Kana. What is this? Height neck ratio. What she says is neck is 15% of the total height. It is high normal only. It should be below 10%. If it is a short neck, her neck length should be shorter than that of the total height. That is, her height is about 100 centimeters, means it should be below 10 centimeters. Then only
tell the measurement, ma. Tell the measurement. You have
Actually, from occipital protuberance to C7 spine, sir.
Sorry. So what was the measurement?
15, sir.
So this one, even if for percentage it accounts to only 10%, isn't it, sir? 150 centimeters is height.
You have to put it like this. Total height is 150 or 155 centimeters. 15 centimeters is below 10%. It is a short neck. That is what I want. Total neck length out of the total height length. What is it? If it is below 10%, it is a short neck. If it is above 15%, it is a longer neck. அப்படின்னா நீ டோட்டல் ஹைட் வந்து 150 சென்டிமீட்டர் சொல்ற 15 சென்டிமீட்டர் சொல்ற அப்படின்னா அது 10% தானே இருக்கு உனக்கு.
Yes, sir.
10 more than
50 ஆமா 10% தான் வருது. ரைட் 10% தான் வருது.
150 divided by 10 தானமா?
இல்ல 15
divided by 15. 115 divided by 15. Okay.
So 10 centimeters. So
10
below is short neck. It is suggestive of CV junction anomaly. That is right. Okay.
Okay.
So you should be clear ma என்ன short neck long neck அப்படிங்கறது நீ மென்ஷன் பண்ணிருக்கிறது வந்து கொஞ்சம் அதிகமா
மென்ஷன் centimeters divided by neck length in centimeters அப்படினு சொல்லி கரெக்ட்டா சொல்ல.
Okay, sir.
Okay, fine.
சரி ஓகே. நீ டிஃபரன்ஷியல் டயக்னோசிஸ்ல CV junction anomaly probable சொல்ற.
Yes, sir.
What are the findings in favoring CV junction anomaly? What are the findings not favoring? Any against it?
Is it low hairline ama patient ku? Is it low hairline?
Yes, sir.
When you say low hairline, when it is below C4 level, we call it as low hairline. Below C4. Okay.
Sir.
What is the triad we commonly come across this? Short neck. Low hairline. Is there any
Klippel-Feil
syndrome?
Klippel-Feil syndrome.
What is the triad called? Fields triad. Klippel-Feil triad.
Short neck. Yes, sir. Klippel-Feil syndrome. Short neck will be there. Posterior hairline, low posterior hairline will be there, sir. And neck movements will be restricted, sir.
Range of movement is restricted. Is there anything like that for this patient? No.
Restricted neck movements Restricted, sir.
Restricted.
Yes, sir.
Told that there is a weakness.
Weakness is there, sir.
Is there a weakness or restriction?
Because of we because of pain, it is the
Spastic weakness அது.
spastic weakness is
அதனால எனக்கு ரெஸ்ட்ரிக்ஷனா?
Very difficult to differentiate, man. There is restriction of movement.
yes, sir.
சரி, ஓகே. அடுத்த வேற என்ன டிஃபரன்ஷியல்? ஏதோ ஒரே சிவி ஜங்ஷன் அனாமலி மட்டும் தான் யோசிப்பேன், வேற எதுவும் யோசிக்கலாமா? வாட் இஸ் அதர் ப்ராபபிள் டைப்?
Other conditions that involve the vertebral bodies actually.
Vertebral body. Subacute combined degeneration
Vertebral bodies I'm asking because patient has got tenderness.
yes, sir.
Yes.
Any epidural abscess, sir? Epidural abscess or hematoma, sir?
Generally metastasis, bony metastasis or osteomyelitis involving the skull base and upper cervical spine.
Yes, sir.
Linear, you said it is subacute combined degeneration. What are the findings against it? There are so many findings against it. Can you say what are the findings in your case against SACD?
Ankle reflex will be normally absent in subacute combined degeneration of cords, sir. But in my case, it is exaggerated, sir.
Mainly posterior column involvement is the
will be typically symmetrical. Okay, here what you said is asymmetrical, and patient is having a radicular neck pain. Will there be any pain in SCD?
No, sir. No, sir.
And bladder involvement has come early. Will there be bladder
Yes,
involvement earlier in SCD?
no, sir.
So these are the findings against it actually. This is very okay.
Okay, sir. So next.
Will it be an Arnold chain malformation? Huh?
It is also associated with CV junction anomaly, sir.
What we come across commonly when you see
There will be herniation of the cerebellar tonsils through foramen magnum, sir. It is of the type 1, type 2 is present, sir. It can be associated with hydrocephalus, syringomyelia.
Patient told some numbness in the shoulders in the history. Is there any way patient having syringomyelia with the ACM?
But in syringomyelia, bladder involvement will be late, sir.
Late. It is
It is
central
not-
cord lesion.
only-
See, whenever you talk about syringomyelia, you should first say it has dissociative sensory loss.
Okay, sir.
Bladder will be early, it is central cord lesion, isn't it?
It's an intramedullary lesion, la.
Yes, sir.
You should mention here about one of the differential diagnoses you can think of, ossification of posterior longitudinal ligament. What is that? OPLL?
Yes, sir. Ossification of the posterior.
Yes, ossification of posterior longitudinal. Will this be a differential diagnosis for your case? Can it be?
It can be, sir.
Yeah, it can also present with chronic myelopathy like this. It can involve C3, C5 also. It can have radicular pain also. It can have bladder involvement also. Yes, you can think of, because it is common in Asian populations, no? Common in Asian populations, OPLL. Ossification of posterior longitudinal ligament is common. Okay, but the only thing we can, which is the best investigation to rule out OPLL?
CT, sir. CT for detecting ossification, CT will be better, sir.
CT is a gold standard, then MRI. But MRI can be taken. but CT is a gold standard for it. So to differentiate from thing, MRI useful for CV junction anomalies and everything, but if it is OPLL, you have to go for CT. CT cervical spine. Okay, okay. What are the other differential diagnoses have you offered for this case? Next slide. Differential diagnosis, can you mention?
No, sir.
No. Okay. What are the differential? Any other differential diagnosis? You said it is SCD, but it is very unlikely. But OPLL can be there. CV junction anomaly can be there based on the history and based on the examination. It can be present. Any other?
Um, intervertebral metastasis can be there, sir.
Okay. What is the commonest which metastasizes to cervical spine? Any common carcinomas? Any common cancers?
Lungs, sir.
Hmm.
Breast also in women, breast CA can,
Breast.
breast and lungs, sir.
But there will be severe tenderness over the spine. It
Yes,
can
sir.
be, and it will be an extradural compression, but it doesn't look like an intramedullary, and the bladder involvement will be very light. Okay.
Yes, sir.
Based upon the height neck ratio and the short neck, our first possibility is CV junction anomaly. Okay.
Okay, sir.
The DDs also you have to write. Usually, when you write the case sheet, you have to write the differentials also. And you present to the case in the final exam, you have to write the differentials also. So if you ask anybody ask now, you should have the idea to rule out all those things. So when I ask that it is due to ulnar cherry malformation with zygomyelia means, you have to explain that. Okay. So still I'm asking that what if, among the CV junction anomaly, what will be the first etiology for this among the CV junction anomalies?
Basilar invaginations.
Okay.
And atlantoaxial instability, sir.
So go ahead. Go ahead.
Sir.
So crucial diagnosis on that.
Yes, sir.
Kippel-Field syndrome is also a possibility in this patient actually.
Investigations. Go for investigations which have proved it.
Investigation. This is the MRI spine, sir.
MRI. There is a compression, high cervical cord. I can be able to see that.
Yes, I'm not able to zoom.
Well, you have
Zoom
taken
it.
a close photo, zoom photo, anything.
Yes, sir.
There is a compression, obviously. So there is a signal change in the cord also,
Yes, sir.
Hmm.
Yes, there is a signal change in the cord, sir.
Cord also.
So classically, the craniovertebral junction cord is completely compressed actually.
Completely compressed.
C2, C3, there is hyperintensity in the cord also.
Foramen magnum, it looks very small.
Very small, sir. Yes.
Solma, findings.
What are all the CV junction anomaly you know, ma? Different types. And this MRI, what it looks like?
It could be associated with Klippel-Feil syndrome, sir. In Chiari-1 malformation can be associated with CV junction anomaly and syringomyelia, sir. Atlantoaxial dislocation can be there, sir. Can be the one cause for CV junction anomaly, sir.
And in os odontoidum, there will be separate ossicle that replaces the normal odontoid process.
And occipitalization of atlas
This what is the finding here? The occipital bone is the shape of the occipital bone is different here. Protruded. Looks like a protruding occipital bone. Okay.
What is the MRI finding? There's a radiologist given for this.
Yes, sir. CV junction anomaly, congenital block vertebra, and
Given as Atlanta axial dislocation only, subluxation, along with basilar invagination.
Okay. At மேல இருக்கு பாருமா Atlanta axial subluxation along with basilar invasion causing foramen.
Atlanta axial subluxation along with.
Okay.
Yes, sir.
The symptoms have been present for past duration of
6 months, sir.
6 months.
Okay.
How are you going to treat the patient?
Treatment, surgery, sir.
Yes, mainly surgery. We need foramen magnum decompression.
You
Actually,
know the lines, Amma. You know the lines and all. X-ray, they have put some lines for this.
Yes, sir.
No pair மட்டும் சொல்லு. Tell me the names.
CV junction anomaly என்ன டைப் ஆஃப் எக்ஸ்ரே நீ ஆர்டர் பண்ணுவ அதுக்கு? MRI இல்ல உங்ககிட்ட இப்ப CV junction anomaly எக்ஸ்ரேஸ்ல பார்க்கலாம்னா என்ன டைப் ஆஃப் எக்ஸ்ரேஸ்ல பார்க்கலாம்?
Extension and flexion, sir.
Okay.
Like extension and flexion. Dynamic extension and flexion.
We have to take an X-ray side with the open mouth. That is a odontoid process. Okay.
So you know the lines, so few of the lines you should know.
Chamberlain lines, sir.
சரி அதெல்லாம் எப்படி எடுப்பாங்க எக்ஸ்ரே? lateral view they will take. அப்படிதானே எடுப்பாங்க?
Yes, sir. Lateral.
அதான் சார் கேக்குறாரு எந்த வியூல எடுப்ப?
Lateral cervical spine. McRae lines, sir.
ஒரு 4 lines சொல்லிடு. Tell me some few lines about that. Chamberlain's line, McGregor's line, அப்புறம் என்ன?
McRae lines, sir. McRae
line.
We'll also see atlantodental intervals, sir.
சரி okay. We don't know about that all these things. சரி go ahead. What do you do to this patient? So you found out the etiology. What
decompression, sir. If there is atlantoaxial instability, we can do stabilization and fixation, sir.
Okay.
Here we should do foramen magnum decompression, sir.
Okay, the definitive management is foramen magnum decompression, but we have to treat the patient. We have to treat the spasticity. We have to treat the pain.
You are told that edema is also there.
Steroids to reduce edema, sir.
What about spasticity?
Baclofen.
You reduce spasticity.
If this atlantoaxial joint subluxation is not stabilized, what are the complications this patient can have?
There can be respiratory paralysis.
Yes. Actually, even if this patient has a mild trauma also, he can go for medullary compression and respiratory failure and death.
Yes.
Even a minor trauma can precipitate it. Okay. So we have to stabilize this also. If it is atlantoaxial subluxation is the main cause, you have to stabilize it. Without stabilization, the patient is more prone for sudden death from the medullary compression.
Okay, sir.
What is the mortality rate of untreated CV junction anomaly with myelopathy with mild involvement like the spinal cord involvement? If you are not going to treat and you have diagnosed this patient as CV junction anomaly, the patient is not willing for any surgery. What is the mortality rate the patient have?
No idea, sir.
It is another 5 years, the patient can have mortality of what they have said is more than 50 to 60% due to respiratory failure. So
Okay,
once the compression features have occurred, you have to go for stabilization, and surgical treatment is option. If the patient is not willing, in another 5 years, the patient will end up in respiratory failure, 50 to 60% chances. But more than CV junction anomaly, what we can see in this certain patients is OPLL, ossification also, which has a definitive surgical approach than this CV junction anomaly.
Okay, sir.
Okay, ma.
So this case, you have to, what is the main take home message? What is the main points you have learned from this case, Linnea?
So,
This is a high cervical cord lesion.
cord lesion,
Okay.
sir.
Yeah, it is
And
like a
I
similar
should
to
be
compressive.
precise about the level of lesion, sir. Precise about the level of lesion and the associated DDs in that area, sir.
Yeah, reflex level, vertebral level, sensory level, everything may change because based on your clinical findings, what is the level? So you're
Okay.
localizing above that, that's all. You cannot exactly say until vertebral tenderness is present, you cannot exactly say the exact level.
Yes,
And
sir.
you can offer a differential diagnosis based on your so much findings, which is the most probable differential diagnosis based on your clinical examination. Finally,
Yes.
investigation will say you a lot of information. Okay.
Okay.
But
Okay.
this, with so many findings, we can think it of for CV junction anomalies, the probable CV junction because of short neck and all these features. You have to think it. Why this patient didn't develop any of the symptoms like this? Only for the past 6 months she is presenting to you. Now she's 40 years, huh? 40 years, huh?
44, sir. 40.
44. Only past 6 months she's having symptoms. Till now she didn't have any symptoms. Any idea about it? Okay, sir. Vinod Khanna, sir. Any questions, sir? And Muthukumaran, sir?
Only இல்லை சார். So other the definite management is surgical. Anyhow, we have to treat the patient's pain, stiffness and all. How are you going to treat that spasticity and all?
Uh, Steroids can be given, sir.
Spasticity. Steroids only for edema. That will be useful only for a short period.
Okay, sir.
Spasticity என்ன கொடுக்கலாமா? Any central muscle relaxants?
Diazepam can be given for spasm, sir.
Yes, not
Yes.
any other central muscle relaxants.
It reduces neuronal excitability by
Baclofen.
modulating GABA receptor. So we can have centrally acting or peripherally acting also. We can go for it. Baclofen, tizanidine,
Tizanidine.
dantrolene.
Yeah.
What are the other ways we can reduce spasticity? The purpose of reducing spasticity is to prevent contractures
Yes, sir.
and make the patient ambulant, and it will also
Physiotherapy
reduce
can
the
be
pain.
given, sir. Okay. Physiotherapy.
Other than that, is there any injections available for spasticity?
Botulinum.
Yes, botulinum toxin can be given.
Yes, sir.
What else we are going to treat with this patient?
Surgical decompression.
Other than that,
If you decompress the anomaly, will the spasticity will come down?
No, sir.
there's produced myelomalacic changes in the cord also.
Yes, sir.
There is a permanent damage. When you see inside the cord, the
Yes, sir.
small hyperintense signal is there. Means it is a myelomalacia. So already the damage has happened to the cord. So even though if you decompress, some sort of spasticity will be there. We can arrest the progress of the disease, but some sort of spasticity will be there. Okay. It'll
You
remain.
can give intrathecal baclofen pumps for reducing spasticity.
Okay, sir.
Any neurocutaneous markers you can look for in CV junction anomalies, Linnea? You said no neurocutaneous markers in this case. This is
Yes.
finally turned out to be a CV junction anomaly.
Yes, sir.
What would you look for? This neurocutaneous markers would have looked for this case.
We can.
You mentioned in the clinical examination also inspection posterior.
A posterior hairline, sir.
And if there is a sacral hair tuft seen in the sacral region, dermal sinuses, okay,
Okay.
and any skin tag or spine
Thin
can be seen.
dimples, sir. Okay, sir.
Yes, and if at all it is similar to CV junction anomaly, capillary spots, neurofibromatosis can cause compressing a cartilage intramedullary. So you can think of many things. You have written no neurocutaneous markers. In this pertaining to this case, what you have looked for, you should know. Okay.
Okay, sir. Okay.
So final word, Vinod Khanna, any things you want to add?
You told that it is a corticospinal tract involvement. Normally, which movements will be affected normally? For example, in stroke patients also, in this type of lesions also, which muscles are predominantly get affected in the corticospinal tract lesions in upper limb and lower limb?
Upper limb extensors are affected, sir.
In a pyramidal type of weakness, I'm asking. What are the extensors which are affected commonly in corticospinal tract involvement?
Triceps, sir. Upper limb.
You told the extensors, correct? You told the extensors. What are the extensors? Wrist extensors, finger extensors, elbow extensors, supinators,
Shoulder abductors, external abductors.
adductors. These are common muscles affected in the upper limb. Lower limb?
Lower limb, knee flexors like hamstrings, sir. Hip flexors, iliopsoas, ankle dorsiflexors, sir. Tibialis anterior.
So, since Sarah asked that where we give Botox, we have to put the Botox according to this muscle weakness, muscle stiffness as well as the weakness. Okay.
You have to put it in these stiff muscles.
Stiff muscles.
Okay, sir.
Okay, ma, that's it. Fine. Questions are over from my side.
Sir, okay, sir. She has
Okay,
come
sir.
to the end of the presentation. And Saravanan, sir, are you on the line?
Yes, sir. I'm on the line. I think three of you really discussed the case very nicely. But only thing is, the suggestion to Linnea is don't stick on to only one diagnosis, Dr. Since I think the way which you discussed and keep on coming back to CV junction anomaly made me to think that you're completely biased with the diagnosis already established with the imaging. Am I correct, doctor? Just open-minded. You try to have the clear points about what is the motor system involvement level, sensory level, and the autonomic involvement and the vertebral involvement. Those things can be completely assessed by you and try to think about possible differentials. Keep always differentials because each and every discussion, the Dr. Muthukumaran sir was coming back to not making you to diagnose only CV junction anomaly, but you keep on coming to that point. Try to deviate and try to understand the examiner's point, what they're trying to tell you about. And important basic points also Natarajan sir was talking about, and Vinod Khanna sir also. So I think might have got a clear idea about how to present a case of quadriplegia Dr. Linnea. So really appreciate all the, and thanks all the faculties for this wonderful discussion on this quadriplegia patient, and appreciate Dr. Linnea for a wonderful presentation. Thank you every one of you and good night to all of you. Thank you.
Thank you, sir. Thank you, sir.
So much, sir.
Thank you very much, sir. Thank you all. Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you so much, sir. Thank you.
Thank you, sir.